Good evening, and happy Monday. And I hope you had a great weekend, and I hope you have had a great Monday and a great start to your week. Today, we're going to be talking about a topic that's very near and dear to my heart, no pun intended. I manage a lot of patients with congestive heart failure, and one of the more humbling things that we see in our practice are patients with severe congestive heart failure who come and, they're really near the end of the rope, and we do a lot to turn them around. And there are a number of times when we're not successful. Over the time, we've evolved and revised our approach to managing patients with heart failure. What I'm going to do is I'm going to share with you some things that we do to use an integrative approach. The subject is the natural approach to treating heart failure, but it's really an integrative approach. And I'm going to share some things with you. I'll share some slides, but I'll also make some comments outside of what's in the presentation to give you some insight in a very complex and difficult disease to manage. So if you or a loved one have congestive heart failure, you know someone with congestive heart failure, this is going to be a very informative show. So get comfortable, sit back, and get ready for the Fresh Natural Live edition for Monday, April 5th. We look forward to seeing you on the other end. Let's get started. All right, hello again. And so I'm not going to delay too much. As I said at the onset, we're going to be talking about heart failure. And I want to bring on two of my esteemed colleagues who are going to be involved in the discussion tonight. Dr. Pam Atkins, how are you doing, Pam? Good evening.
Good evening. I'm doing great.
What'd you say? How's your Monday going?
It's going well. It's a peaceful weekend, so I'm not complaining.
You look like you've been at peace and relaxed, so no, that's good. And Dr. Palmer, hello, how are you doing?
Hello.
Did you have a peaceful weekend also?
It was kind of a busy weekend.
No, I understand. Mine was a mixture of peace and business. So as I said at the outset, we're going to be talking about heart failure, and we're going to talk about the natural treatment of heart failure. Many of us know that, the number one cause of death in men and women in the United States is heart disease in general. Heart failure is at the helm of that. And so what I'm going to do at the outset is talk about heart disease. How does the heart work? So I'm going to give our audience some basic information about heart disease. And in part one of my discussion, I'm going to talk about the conventional treatment for heart disease. So I'll talk about what is heart disease, what is heart failure, and I'm going to talk about how we normally treat heart failure in general, or heart disease in general, more specifically heart failure. And then once we've done that, we'll take a break, and then we'll get into some of the nuts and bolts of treating heart disease naturally, or more specifically in an integrative fashion, because I think it's important to understand that sometimes we have to integrate things with some of the conventional treatments until patients recover. And I'll share a couple of case scenarios toward the end. Hello, Catherine Welch, and hello, Karen Evans. Welcome to the show tonight. Thanks for joining us early. So without further ado, let me just bring up my slides here. Can y'all see that okay? Is the print too small? Do I need to make it larger?
It's okay.
Okay, good.
Looks
so
good.
Again, the food prescription approach for treating heart failure. And I really want to emphasize this, and although I'm not going to get into the food classification system, I have another presentation on that. But the food prescription is an intentional phraseology, if you will, because I think we need to be very precise in terms of how we recommend nutrition. And I'm going to share some of that, a little bit of that with you when I talk about the specific patients that we're caring for. I have a couple of case presentations, and I'll discuss some other patients we're working with clinically. But prescribing food is not just a matter of saying, okay, eat healthy or low calorie or eat vegan or whatever. We have to be very precise. So I think that's important. And so the natural intervention is really key. So let's start off with, how does the heart work? The heart works like a pump, and then we are probably all familiar with that. Beats 100,000 times a day. There's a right heart and a left heart. We think of conventionally. The right side of the heart pumps blood to the lungs, picks up oxygen, where the oxygen's picked up in the lungs, and oxygenated blood is delivered from the left heart to the body, systemic circulation. So the heart on the left side receives oxygenated blood, and the left side is, I don't say the more important side because they're both important, but the left side has a lot of demand on it from the standpoint of a lot of demand on it for the standpoint. I think we lost Celeste there. I think she may have, hopefully nothing bad has happened there. We'll wait till she comes in. It's under a lot of pressure because there's a lot of resistance to flow on the left side compared to the right side. So when we deal with heart failure, we're usually talking about failure on the left side, although there is such a thing as right heart failure, especially in people with lung disease, and that could cause a lot of problems as well. The heart has its own circulatory system. You have the main artery that feeds blood, that blood is fed into from the heart, but there are branches from that main artery. The first branches that come off of that main artery, called the aorta, are the coronary arteries. Coronary meaning crown, and these are arteries that sit like a crown on the outside of the heart, over the heart, and it has many branches, hundreds of millions or trillions of branches that penetrate through the heart muscle, through every cell, where oxygenated blood is carried to the heart muscle tissue. Heart has an electrical system. As a cardiac electrophysiologist, we did a lot of work with the heart's electrical system. You have your intrinsic pacemaker. We call that the sinus node. The AV node is like a filter between the upper and lower chamber of the heart. The Hypercholesterolemia system is a conduction pathway that allows electrical activity to conduct efficiently through the heart. And so we have a lot of patients who have electrical problems with the heart. You may know someone who has a pacemaker, for instance. That's maybe if you have abnormal conduction here or a problem in the sinus node, the heart is slow, or you may have conduction problems here where the conduction from the upper to the lower chamber is affected, or anywhere along this, connection here. Some individuals who have electrical problems, such as damage to the heart muscle, and the wires could be short circuit due to scarring, are at risk for cardiac arrest. So they may have a cardiac defibrillator. Many individuals with heart failure can have electrical damage. So the electrical system, as we'll go into in a minute, can be damaged. And so that's what we're dealing with. So what is heart disease? Basically, it's an umbrella term for the disorders that affect the normal function of the heart. Now, we often think of cardiovascular disease and someone on there saying, I have AFib. And we'll talk a little bit about that. Cardiovascular disease, which means disease of the heart itself and blood vessels. And so heart disease frequently is used interchangeably with cardiovascular disease, because oftentimes someone says, I have heart disease, and maybe they have atrial fibrillation, and they've had a stroke, and so there's cardiovascular effects, and maybe they've had a heart attack, so that's more of a vascular problem, or they may have peripheral vascular disease and heart disease, so they probably have systemic atherosclerosis that's affecting the heart and also affecting the periphery. But heart disease is kind of all-encompassing structural disease of the heart itself, with disease in the vascular system that may affect other organs and tissue. So we'll use that interchangeably there. So that's this back. So again, how can the heart malfunction? Coronary artery disease, as we alluded to earlier, you can have a heart attack. That's when the blood vessels become damaged. Typically, inflammation, oxidative stress. These are the things that result in initial damage to the coronary vascular wall. You have plaque that builds up. You can have initially a thin core, fibrous core that can rupture. And if it's an unstable, friable fibrous core, it can rupture. And that predisposed to a heart attack, because essentially when that fibrous core rupture and the substances below that fibrous core get exposed to the blood, triggers a biochemical cascade of reactions that causes thrombus formation. And so a lot of things we do for heart disease is to reduce inflammation, reduce oxidative stress, and decrease this process of unstable plaque and rupture. And we actually draw blood, a special blood test in our lab that can give us insight into whether or not you have significant amount of friable or unstable plaque. Valvular disease, you can have scarring valves that can cause tightness of the valves and stenosis. So fibrosis or inflammation over time can cause the valves to become stiff and stenotic, so where they don't open adequately. Or you can have a loose valve that causes leaking or regurgitation, as we say. So, when the valves don't open normally, or if they don't close normally, you get insufficient flow that causes the heart to work more, and so it can lead to heart failure. And many individuals have to have valve replacement or valve repair to minimize the progression of heart failure. Electrical disease, abnormal slow conduction. We alluded to that before. If you had a pacemaker dysfunction, so you may have to have a pacemaker implanted. Abnormal fast electrical conduction, tachycardia. Again, that's something that could predispose to sudden cardiac arrest. This disorderly electrical conduction. And so you can see this little diagram here that shows someone in polymorphic VT. VT is called ventricular tachycardia. Ventricular stands for the lower chamber on either the right or the left, and tachycardia means fast heartbeat. So a fast, erratic heartbeat from the lower chamber. So electrical disease, valvular disease, coronary disease, all can be components of heart disease. And frequently we see patients who have all of these combined. So they come in, they have electrical disorders, valvular disorders, and coronary disease. And oftentimes they may need procedures to correct all of these problems. There can also be disease of the primary heart muscle, hypertension, even though we think of that as a systemic problem, which it is, and it increases resistance to flow and stress on the heart muscle itself. It also is associated with biochemical processes such as increased renin-angiotensin, which stimulates little cells called fibroblasts, and these fibroblasts cause scarring, which can potentiate heart failure over time. It starts with hypertrophy, and then that can progress to heart failure. You can also have diabetes, which potentiates similar pathophysiological processes within the heart muscle, and there are other systemic diseases that are infiltrative, amyloidosis or sarcoidosis. These could all be conditions that have infiltrative processes in the heart and cause a primary or secondary disorder, causing a primary structural abnormality in the heart. And as I alluded to here, systemic illnesses, infections, autoimmune diseases, substances such as alcohol. Alcohol itself can be a toxin to the heart directly. And so congestive heart failure, this is not a rare problem. We see a lot of it. We think of congestive heart failure or heart failure in two forms: as a diastolic heart failure when the heart is too stiff. And so with the heart being stiff, it doesn't allow for adequate filling. So the heart doesn't relax enough to allow for enough volume to fill. So even though it may contract normally, it may have a normal ejection fraction, which is a percent blood that's excreted with each beat. The circulation may be low because the filling is low. The other side is systolic heart failure, in which case we have the ejection fraction is low. So normally the heart should squeeze about 50% or more, say 55, 6% of the blood should be ejected with each contraction. That number is often low in some individuals. It could be 30% or 20% or 10%. I've seen 5% ejection fraction is very low. Frequently, individuals could have both. We see a lot of people with systolic and diastolic heart failure or dysfunction. And so these people are very severely ill and need a lot of aggressive attention. So quick little word on hemodynamics. You might want to take a picture of this slide. I don't want to get too technical on you, but I want to share this information with you because when we talk about the findings of how our patients improve, some of these terms will be used. They're very simple. Ejection fraction is the percentage of blood that's ejected from the heart, from the left ventricle, primarily. You can have a right ventricular ejection fraction, but when we talk about ejection fraction in this presentation, I'll be talking about left ventricular ejection fraction. That's percent of blood that's squeezed out of the heart with each beat. Stroke volume is the volume of blood that's excreted with each beat. So ejection fraction is the percentage of whatever volume there is. So you may have 1 liter of volume starting in the chamber, and if you eject, 50% of that, then you eject 500 mLs. But the stroke volume is the absolute amount. So you can have a normal ejection fraction and a low stroke volume. So you have patient A and patient B, they both have an ejection fraction of 50%. But patient A may have a larger stroke volume than patient B because patient A may be filling their chamber to a liter and they're ejecting 50% of a liter, which is 500 milliliters. But patient B may be filling only 500 milliliters at the beginning. So they eject 50%. That's only 250 milliliters. So the stroke volume is the absolute volume, and the ejection fraction is the percent of whatever volume you're talking about. And as I said before, if you have diastolic dysfunction or a stiff heart, the less amount of volume goes in. So a normal filling heart may fill up to a liter and eject 50% being 500. A stiff heart may only fill up to 500 milliliters because it's a stiff balloon. So it only allows 500 mLs in. So it may eject out half of that, which is 250. So the amount of volume that's circulating with every contraction is lower here than here, even though the ejection fraction is the same. Vascular resistance is the amount of tightness of blood flow, the blood vessels rather. And so there's a restriction to flow, the increased resistance to flow, the more the heart has to work to circulate the blood. High blood pressure is associated with increased vascular resistance. And then you can have increased resistance to flow or afterload. So the heart muscle is working hard. So you can have people with thickened hearts, thick and stiff hearts because it's working against a lot of resistance to flow. Cardiac output is the total amount of circulation of blood. So it's a volume circulation. So typically 5 liters a minute, but you can have more, you can have less depending on what your activity level is, so on and so forth. So cardiac output is the total body circulation. And the heart size, bigger is not necessarily better. So if you have an enlarged heart, it could be due to it's working too hard, it could be too thick, or dilated, or both. And so this is where a big heart is not to your advantage. So we have a heart failure burden. I'm not going to go through the details of this. This is some old data from an old slide, but the bottom line is, heart failure is a very prominent problem. It's the #1 cause of death, and it's associated with other types of dysfunction. So many people with heart failure will start to have other organs to fail because typically when the heart fails, circulation to the kidney, circulation to the liver can become congested. So many patients with heart failure have what we call as a congestive hepatopathy, meaning that they have congestion in the liver. The liver becomes swollen and scarred and dysfunctional as a result of long-standing heart failure. Similarly, with low flow to the kidneys, they can start to have kidney failure. So heart failure patients, they die by 2 mechanisms: 1, pump failure, and 2, sudden death. When we talk about some of the treatment, we'll talk about how we treat these 2 conditions. So medical therapy, as we look at medical therapy, and I'm not going to go, this is a busy slide, and I'm not going to go through the details of it. It's worthwhile taking a picture. This is pretty busy, but the medications that we use to treat heart failure do a series of things. 1, because circulation is low, the body behaves as though it's in shock. And so part of that mechanism is at the level of the kidney. The kidney secrete a number of hormone cascades that trigger increased vascular resistance. It triggers increased catecholamine outputs because it's flogging the heart to say, okay, hurry up, we're in shock, beat more, beat faster, beat stronger. And it also retains sodium. And so we retain fluid because the kidneys are not getting adequate circulation. So the kidneys are thinking that we're in shock. They think that maybe you had a car wreck and you're bleeding out, you need to retain fluid, but that's not necessarily the case. So heart failure patients become edematous. The heart rate's typically higher, and there's vascular resistance because the body's behaving like it's in shock. So these compensatory mechanisms to the initial low flow actually can work against the heart, and they trigger a cascade of progressive failure. So the medication we use are used to reduce some of the sodium, reduce some of the fluid retention, relax the blood vessels. So we use vasodilators. We also give beta blockers to suppress the amount of adrenaline stress on the heart, because the heart's under excess stress from adrenaline too much. Again, it can add to the adverse progressive failure of the heart. So the medication we use are meant to blunt these overall compensatory effects, which could also be damaging. Again, some of the other treatments, patients with heart disease, coronary disease, so if you have multivessel blockages or the like, we will maybe revascularize the heart. Sometimes heart failure is due to the fact that certain parts of the heart muscle is not getting adequate blood flow, and so the heart is weak as a result of that. The heart will preserve itself. So just like when you're tired and you don't have enough energy, you may go and rest. The heart will do the same thing. We see what we call hibernating myocardium. The heart rests when it's not getting adequate flow. When you improve the oxygenated flow, then the heart will pump more effectively. So revascularization is an approach we use. Balloon angioplasty is one. As you can see here, bypass surgery is another approach that's used. For individuals with advanced heart disease, maybe you had a heart attack, and if you have heart attack, scarring of the heart, that puts you at risk for sudden cardiac death. Defibrillator implants or pacemaker implants, if you have conduction abnormalities, are all beneficial for people with heart failure who are at risk for sudden death. As I said before, two mechanisms of death. Number one, sudden death. Many studies we've done over the years have shown that individuals with an ejection fraction of less than 35%, even if they don't have any signs of an arrhythmia, just by implanting a defibrillator, population studies show that there's a survival benefit to doing this compared to individuals who are just treated with medications alone. Now, granted, these individuals are not treated with a natural plant-based diet. I just throw that out there because as we talk about the use of a natural plant-based diet, we're going to talk about how it might benefit in terms of reducing cardiac arrhythmia. So the other mechanism of how you die from heart failure is due to, and this is an external defibrillator, by the way, and this is an implantable defibrillator. And this is an ablation procedure that's being done where the heart's being mapped out, and they're probably ablating VT or doing a pulmonary vein ablation. Somebody mentioned they have AFib. A number of years ago, almost 20 years ago, I started doing pulmonary vein isolation to treat AFib from an ablation standpoint. So that can be helpful in terms of treating ablation. Pump failure is the other way the heart that you die from heart failure. And so when the heart progressively gets worse, multiple organs start to fail, and the person just dies. The liver fails, the kidney fails, you start to bleed. It's really a not so fun way to die, if you will. So in these patients, they offer heart transplant as a possible treatment. You may get an LVAD, which is called a left ventricular assist device. This is a diagram that shows that, where this device pumps blood from the left ventricle and recirculates to the aorta. So it takes the stress off of the left ventricle. So heart transplant, mechanical assist are ways that we typically treat individuals with heart failure. So I want to kind of get us started there, lay the groundwork. What is heart disease? How does it work? How does a heart fail? And for the next part, I want to get us into this phase of talking about, this food prescription for heart failure. I'll show a few slides that help out with that. And then what I'll do is get into some discussion. I know there's some questions and comments in the chat. I know my colleagues are keeping an eye on that. So if y'all can help me with those, we'll go into the treatment for heart failure. We'll probably try to touch base on some of these questions. So Pam, Celeste, if y'all can kind of look at those and have them ready for me, we can go into that on the next side of this break. Okay, so there are a few comments. Barbara from Savannah, Georgia. Hello, Barbara. Sonia Allen. Hello, Johnny M. Jackson. I have a fib. I hope that's under control. And any questions? Let's see. Y'all see anything that we need to take care of right away? Start week 2, 28-day raw detox today. Yay. All right, Ms. Harris. Any comments over here?
One lady looks like she asked about a detox. She just got an implant and was given some antibiotics, and she's on the second week of her 28-day detox. You see that one?
Okay, she got an implant?
Yeah. So fleet underneath that one.
Oh, okay.
Yeah.
Okay. Not heart related. I'm on the second week of 28 detox. I just got implants today, and the doctor prescribed antibiotics. Will the negative impact on my detox? Well, I mean, detox, I don't know what kind of implant it is, but let's say if it's a surgical procedure that led to the implants, anytime you make a surgical incision, you're going to trigger some inflammation. And my experience in patients, and in fact, even my patient, I've had some patients we've had to take pacemakers out because they're infected and whatnot. And I've had them on a raw detox, and the wound healing actually is impaired. There's actually some scientific data that shows that as well. And so, yes, a detox can positively impact someone who's in the perioperative state, in my clinical experience, and there's some evidence that show that as well. So it shouldn't have an adverse effect. The antibiotics are the antibiotics. And so once you're done with the antibiotics, you may want to add a probiotic to your regimen to counter that and do other types of things that are probiotic friendly, such as hopefully the detox is a plant-based diet detox, because that helps rebuild the gut flora as well.
She said dental implants.
Dental implants, yeah. So I think either way it should be fine. As long as you can chew the food, you should be fine. What are doctors looking for on EKGs, and what problems may be detected early using an EKG? That's a good question. So abnormalities on EKG are varied. So, there could be electrical abnormalities. So you may have, abnormal beats, and the specifics of EKG finds beyond the scope of this discussion. But what I will say is this: there's specific patterns on an EKG. So there's like a little bump, it's called a P wave, and a QRS spike, and a repolarization. And we look for that repolarization, bump spike repolarization signal that go consistently through. We look at the size of the spikes, which indicate the normal amount of muscle tissue. So the types of things that we look for on EKG are things such as, we call them Q waves, where a spike should go up, and it doesn't go up, it goes down. So that's an abnormality. The spike that goes up, represents electrical conduction through the lower chambers. So if that spike, instead of being narrow, is wide, then that would tell me that there's probably some structural abnormalities in the lower chamber. That could be arrhythmia beats. It could be PACs and PVCs. So a PAC, premature atrial contraction, where there's an early beat that starts from the upper chamber, or there may be an early beat that starts from the lower chamber. So these could be signals, signs that there may be some problem with the heart. And so these are some of the things that we look for in EKGs, along with some of the other clinical things that we look for. But that's a great question. One of the things I think about when I see an EKG with a wide QRS complex, I say there's some structural issue with the heart. I mean, it's what if the QRS complex, it could be a bundle branch block, or it could be a non-specific interventricular conduction abnormality. Those are technical terms, but the bottom line, if that spike is broad, then that tells me that there's something going on with the heart muscle, particularly in the lower chamber. Yes.
Something too for pediatrics.
Yes.
And our kids, sometimes when we are doing our school physicals activities, because we've had some incidents where children have passed out on the field, and that was the end, and they had a hypertrophy and nobody knew. So the EKG we do to make sure, like Dr. Montgomery was saying, that there isn't abnormality in the wave that would let us know that something is abnormal with the heart that may have never presented clinically in a clinical setting before, or the parents never detected. So it's Some schools are saying everybody should get one. A lot of them are giving parents the opportunity if they want to get one, because some of these heart conditions are not detectable until that day when something bad happens.
Yeah, and that the whole and that's a good point you raise, and the whole issue of hypertrophic cardiomyopathy. It's the number one cause of death, sudden death in young athletes, and there's a lot of controversy in the EP community because there's some people say, well, should we screen everybody with EKGs? Should we screen everybody echoes? And some people say, well, you can, whatever the case is. And it's challenging because you get a bunch of EKGs and you'll probably see some non-specific abnormalities. And then that may lead to other testing. One can make the argument, hey, okay, if it's going to save one life, it's worth it. You can have hypertrophic cardiomyopathy and not see it on the echo or not see it on EKG. I mean, cardiac MRI will be more sensitive to pick it up. You may see some borderline LVH, and I see a number of these kids from time to time, and I may see some borderline LVH or thickening of the heart muscle, and I may say, okay, have you ever passed out? No. Has anyone in your family died suddenly? No. And so there you left. Okay, EKG looks a little bit suspicious. So what am I going to do? And oftentimes I end up ordering a cardiac MRI. Anyway, now if someone has symptoms, they're passing out, there's some things going on, then I'll have a lower threshold for ordering a cardiac MRI. But it's a difficult issue to deal with because, as you said, somebody dies suddenly, and it's like, oh my goodness, and you don't know. And then the question is, should I have screened everybody? And it's a very tragic thing, that sudden cardiac death in athletes.
Yeah. Okay, go ahead.
No, go ahead.
Oh, I wanted to say also in adults, when you look at the EKG, you can see ischemia, so it can give, if you have poor circulation to the heart muscle, or if you've had a silent heart attack. I know Dr. Montgomery Baxter can tell you, you can see you may have had evidence of damage to the heart or a heart attack that you were not aware of. So EKG can screen for that as well. Correct?
No, that's a great point. Yeah, especially the ischemia, because a lot of people have resting ischemia, and they don't have chest discomfort. And so a lot of times you'll see ischemia on the EKG without them doing anything. And so, and then you may do one EKG, you see ischemia, and the other EKG you don't. And that shows, okay, there's a dynamic process. So certainly ischemia is an important one as well, in addition to, like you say, a picture of a silent heart attack from before. Important point. After your valves are repaired, are you no longer considered a heart failure patient? That's a great question. So there are many people with valve disease who get the valves repaired, and they're not in systolic heart failure. They may have diastolic heart failure. The answer is not necessarily. I mean, you can have heart failure and have the valves repaired, and your heart can recover partially, but not fully. And so there may be other factors contributing to your heart failure. So a simple surgical procedure that repairs the valve may make you better, but it may not totally correct the underlying problem, because oftentimes there are multiple factors contributing to your heart failure. So for instance, systemic inflammation, oxidative stress, and things we're going to talk about predispose to inflamed valves that becomes either stenotic or regurgitant, but that same underlying process that caused inflammation is also weakening the heart or stiffening the heart or both. And so you may fix the valve, but then the heart is still suffering from the primary underlying condition. So it's not enough to just surgically repair the valve. You got to treat the underlying problem that got the valve, that led to the valve disease, and also is contributing to the part of the heart disease as well. So that's a great question and what have you. Let me just take one more, and then we'll go to the rest of the presentation, and we'll catch these others down the road. I was diagnosed with SVT several years ago and had an ablation procedure. Is there a chance of recurrence? That's a great question. SVT stands for supraventricular tachycardia. Supraventricular meaning above the ventricles. Tachycardia, fast heart rate. It depends on the mechanism. So SVT, due to what we call as avianodal reentrant tachycardia. I'm not going to be. It's just the jargon is not important, but some mechanisms of SVT are virtually curable. So of all the disease I ablated, AV and RT, about 100% of them went away and never came back. The same thing goes for all the AVRTs. The ablation I did for the Wolff-Parkinson-White, concealed Wolff-Parkinson-White, when I ablated those represented a cure. Now, there are some exceptions to the accessory pathway. So I may ablate one pathway, and there may be another pathway that's quiescent because the primary pathway is suppressed. So when I get rid of the primary pathway, they come back with more SVT, then that's due to another pathway. So I'll have to get two pathways in order to get the cure. AV and RT, the only time I had a recurrence when I started using a very new technology called cryoablation that just came out with the catheters. I cryoablated it, called freezing it instead of burning it. And they had a recurrence. I went back and burned it and got rid of it for good. But by and large, I used to tell my patients 95% cure. That was probably an understatement. It's virtually 100% cure. So typically an ablation of an SVT of those types is almost 100% cure. Atrial flutter, typical atrial flutter, is another one that, it may have been referred to as SVT. Typically, SVT is referred to one of the mechanisms I mentioned. Flutter could be ablated. That's a very high chance of cure. Some of those can recur. Sometimes you may have flutter that cause some structural damage, and some people get AFib. But atrial flutter, the typical atrial flutter is, I would say, 75, 80% cure to be conservative. It's probably more realistic than 90, 95% cure on those. Atrial fibrillation with pulmonary vein ablation. Typically, people get two ablations, and I usually think that more of as an adjunct treatment for the AFib because there's so many other things that contribute to the AFib. Atrial tach ablation, some of those could be cured depending on the mechanism. If it's only one focus, it is. If it's multiple foci, then it's another story altogether. So chances are, if you were told it's SVT, it's likely to be either aviodontal ventricular tachycardia. That's most of the time with women. AVRT, which is a concealed pathway or manifest Wolff-Parkinson-White. Those are usually curable. And if it's something else, then it's a little bit dicier. So anyway, so let's talk about the food prescription for heart failure. Some of these slides are going to be a little disjointed. I want to start off with a patient that we managed. So there's a patient who flew in from Connecticut. History of type 2 diabetes, hyperlipidemia, short of breath, fatigue, low ejection fraction. The clinical history, a little bit complex here, but history of heart failure. He had a single chamber ICD implanted by his cardiologist, electrophysiologist in Connecticut. Type 2 diabetes, had a history of a stroke, had a history of hyperlipidemia, a strong family history of heart failure, and family members who had heart transplants even. So that's a very strong family history. He was having symptoms of substernal chest tight. Now, he saw us last year being 2020 at the time of this taping, and it was during the time of the pandemic. And so many of you know, during that time, a lot of doctors' offices were closed and, people were quarantining and all that stuff. He had not seen his doctor for approximately 8 months, and he was taking a lot of medications. And so he was having symptoms. The last time he saw his physician, they said, look, you need to get a transplant. You need an LVAD. And so he didn't really want to just jump into that. He wanted to try something different. And so he retained fluid in his abdomen for the most part, his symptom. And I think his last echo was, again, more than a year ago. It last been seen 8 months ago. The echo was more than a year. And the ejection fraction was less than 20% at that time. When we saw him on day one, vital signs, blood pressure 96/48, heart rate 78, weight 230 pounds. He was taking these medications. You see allopurinol and magnesium and so on. I hope this is large enough. Carvedilol is a heart failure medicine that's a beta blocker. This is for diabetes. Tradjenta, Eliquis is a blood thinner. Entresto is a heart failure medication. And this is a fairly high dose of Entresto. Torsemide is a fluid pill or diuretic, typically used for heart failure. Torvastatin is a statin for cholesterol. He has a history of hyperlipidemia. He was on Humalog, insulin, Lantus, vitamin D, and potassium. So he was on a lot of medications and had not been seen for about 8 months. No one had drawn any labs on him. So we didn't know what to do. We saw him the first day, did the evaluation. He was having these symptoms of chest discomfort, shortness of breath when he walked, as mentioned earlier. So we drew blood that day. Of course, sent it to the lab. We didn't have the results that day. So we started him on the detox, and he went to his apartment. And so we scheduled an appointment to see 2 or 3 days. When we start detoxes on patients like this, we see them fairly frequently. So someone will come back in 3 days, not 3 weeks, not 3 months, 3 days, maybe the next day. So we've seen patients 3 or 4 days in a week. So the follow-up is very close. So when we got the lab results back, what were the results? Well, glucose 158. Look at his creatinine, 5.08. He didn't tell us he had kidney failure. His GFR is 14. And BUN is 176. So he was in renal failure. In fact, the GFR less than 15 is usually the indication for dialysis. So he was technically in end-stage kidney failure. Cholesterol was, as you see here, he was on a statin. So the HDL cholesterol is 27, total cholesterol 84, and so on. And then his insulin resistance, he has insulin score of 100 and C-peptide. Now, of course, he was on insulin, but he did have some insulin resistance. So we put him on, essentially what we did, we saw him the next day, we gave him IV fluids in the office to try to hydrate him. So, well, maybe this is due to the fact he's on a pretty high dose of torsemide, 60 milligrams. That's a very high dose. So we said, okay, let's stop the diuretics, because we had cut the diuretics in half and reduced some of his medication. We didn't do that fast enough. So we had reduced it more and gave him IV hydration the very next day, which was, I think we saw him initially on a Monday. The next day was a Thursday. We had him come back the next day, which was that Friday. And we had drew labs on that Thursday. Now, we've got weights. I'm going to come back to this slide. It's a little bit disjointed. And systolic blood pressure, I'm going to come back to this slide. Heart rates, I'm going to come back to this slide. And creatinine, we'll come back. But what I want to show you here is the first creatinine we drew on the 14th was this day. When he came back several days later, the creatinine was 12.8. And so I put him in the hospital. And we hydrated him here, but we put him in the hospital on this day. And on the hospital labs, his creatinine was 11.1. So the GFR, I told you 15 is where you say you need dialysis. And he started off at 12 or 14, went down to 7 to 5.5. So he was really in severe renal failure here. Now, we did a stress test on the first day he came in. He only went for 1 minute, okay? Now, we actually detox him over time. I'm going to slip through here. These are some of the medications that we did. And I'm going to go back through some of the slides because this presentation is a little bit different than how I wanted to present today. But we ended up stopping all of his medications upon admitting him to the hospital. I kept him on a raw detox diet. So he got food from a nutrition center, and he took it to the hospital, and we got the food to him on a regular basis. So he was on the detox while being in the hospital. We changed his medication. We took him off the high-dose carvedilol, put him on a low-dose beta blocker, Biosolic. We put him on vitamin D, CoQ10, which is a supplement that we use for our heart failure patients. The blue-green algae is a superfood we use for our heart failure patients, and also sea moss that's mineral-rich. And he had some arthritic pain. We gave him a lidoderm patch. This is for the knee because we wanted to take him off. He had a history of gout and was having some knee problems, and the lidoderm really helped with the pain while we were detoxing him. So over the course of treatment and what we did in the hospital, in addition to the raw detox diet, was essentially just aggressively hydrate him. He was on a large dose diuretic for a long time, and what we did is we aggressively hydrated him. And so his heart rate was 78. Of course, it went up a little bit when we were making the changes, but eventually it kind of settled down and came down because he was essentially dehydrated even more here, and it took more hydration to get that heart rate back down. And plus we had changed his beta blocker, and so he had a little bit of rebound, increased heart rate there. The blood pressure, the creatinine, again, here was very high. And so this creatinine of 12.8 went down and the GFR went up. So what that tells us, the only change we did here was hydrate. We removed the diuretics and hydrate. Now you say, well, this patient has heart failure, and if the doctor's on this chat screen, so wait a minute, you aggressively hydrate heart failure patients? Yes. When their intravascular volume depleted, as this patient was, we hydrated him aggressively. And when we did that, his GFR, or glomerular filtration rate, or the rate in which his kidneys is filtering the blood, improved because he got better hydration. Better hydration led to better cardiac function and better circulation to better kidney function. When that happened, the creatinine came down, the filtration rate went up, and this is almost normal. Normal is probably greater than 60, but he's at 47 compared to 5. So it's about a 5-fold increase in improvement in kidney function from when he was admitted, about a 4.5 to 5-fold, almost a 9 to 10-fold increase, 9 to 10-fold increase in kidney function. So that improved greatly by just simply hydrating him along with a raw detox diet. If we look at his stress test duration time, from 1 minute all the way up to 13 minutes, the green is a modified Bruce. The blue is a Bruce, which is a more aggressive one. So if you do apples to apples, this was 1 minute on a Bruce, went up to 3 minutes. So the stress duration tripled with hydration and improvement of his cardiac function. Heart rate, resting versus peak heart rate difference, we saw that improved. I won't go through the details of that, but the bottom line is that the blue is resting and the peak heart rate is the green. So you had a resting heart rate, blue, that started out lower, 80, and the peak heart rate was lower on June 12th compared to the beginning. So basically that is consistent with better cardiac function. And so we made significant reduction in this medication to improve. Now, there was more work to do, but what I will say about this patient is that we treated him systemically. We adjusted his medications, optimized his medications, and got him better in that regard. Let me just show you one other case study. There's a 46-year-old lady who came to us with an abnormal EKG. She was having chest discomfort that woke her from sleep. We did an echocardiogram and showed an ejection fraction of 20 to 25%. An MRI showed it 24%. She went on a nutritional detox regimen. She was on minimal supplements. She was not on coenzyme Q10, so she was on a natural diet by itself. And we've shown this before, but I'll just show that here's an MRI of the heart. This is the beginning, and you can see the heart is just barely moving. You see this outline border is barely thickening, but here you can see this is thickening significantly. So this is an ejection fraction of 24%. It went up to 50%. And we saw that with an improvement of the diet, reduction of the animal protein, and so on. So we went from baseline here to about 5.5 months. So you can see very significant improvement. So what are the improvements we see? And I'll show this and we'll kind of go to our questions and comments. Ejection fraction, we've seen improve. Stroke volume improves. Vascular resistance is reduced. Cardiac output is improved. And the heart size is reduced. Again, a better ejection fraction is associated with better circulation. A higher stroke volume is associated with better circulation. Decreased resistance is decreased resistance to flow, so that's better circulation. And improved cardiac output is associated with, is by definition better circulation, because that's what cardiac output is, and reduction in heart size, so the heart is smaller and more efficient in how it functions. And so we looked at this in about 15 patients in 4 weeks, and we measured hemodynamics inside our office. And what we saw was the improvement in cardiac output, improvement in stroke volume, decrease in resistance of flow. The volume status improved. The heart rate went down because the heart was beating more efficiently. Systolic and diastolic blood pressure improved. The weight and waist circumference reduced. And even though we didn't emphasize, weight loss, the weight improved largely because they were getting better in many different ways. This graph, again, improved stroke volume, improved cardiac output, improved thoracic fluid content. So all improved circulation and decreased heart size, okay? Decreased resistance, decreased blood pressure, systolic and diastolic, waist circumference, and weight, not heart size, but these other parameters decrease. So these are all anthropomorphic hemodynamic improvements along with improved cardiac performance. We did a case series of patients using cardiac MRI. There's a series of 3 patients. Their ejection fraction averaged about 22%. This was documented for over a year. We put them on food prescription, food level 0 to 4A. I think some of them allowed to eat the 4B. And we got a cardiac MRI before and after, about 78 days apart. And what we saw was increased ejection fraction, improved cardiac output, improved stroke volume, decreased LV mass. So the heart that was thickened and stiff regressed. It got smaller. The diastolic volume and systolic volume decreased. So in other words, the heart got stronger, it got smaller and stronger. So an enlarged heart became less enlarged. A weak heart became stronger based on these parameters that we measured. And so here's the data here. Ejection fraction of 22% going to 42. They went from needing a defibrillator to not needing one. And again, similar to what we saw before, the heart got stronger, better ejection fraction, better stroke volume, better circulation, and it got smaller in this case. Decreased LV mass, end diastolic, end systolic volume improved. And these are the graphs showing the same things here. So again, I showed this slide. This is a busy slide, but what is going on? There are a lot of things that have happened biochemically, systemically. What I want to point out here is that what we see with a defined plant-based diet is we see a reduction in inflammation. C-reactive protein is reduced by greater than 30%. IL-6 was a cytokine is reduced by 23%. And so a lot of these inflammatory markers are reduced significantly. Myeloperoxidase, trends toward reduction. So we see significant improvement in a lot of these parameters that are inflammatory markers. So it's very likely that decrease in inflammation and oxidative stroke is something that we see as a result of this. And when we use supplements such as MSM, coenzyme Q10, that improves myocardial function, reduces oxidative stress, and also help reduce inflammation. So that hopefully gives you some mechanism in terms of what is done with heart failure patients. I have a patient right now who's in very dire straits, and we're trying to get her. She's going to be on hospice, but we're working to reduce oxidative stress, reduce inflammation, and aggressively treat her heart failure to kind of turn her around to improve her condition. We've had another patient, a young patient that I'll probably bring on the show one day, young man in his 40s, early 40s with bad heart failure. He came to us from Illinois, and he was just told that, look, you get an LVAD, we can make you comfortable, but you're going to die real soon. But fortunately, he was able to come, and we got him started on a raw diet. We had to put him on milrinone. He had AFib. He had an AFib ablation, but also the antioxidant plant-based diet, et cetera, has allowed him to stay out of AFib. And we also have gotten him off of the milrinone, which is an infusion. He was having to walk around with a pump. We got him off the milrinone, so he's doing much better. He's exercising. We still have a ways to go, but these patients we can capture them, rescue from that slippery slope. We have to be very aggressive with a very aggressive antioxidant diet with superfood nutrients that help improve myocardial function, improve overall biological and systemic function there. So I've said more than a mouthful, but I wanted to kind of sort of throw that information out. And are there any questions y'all saw? I think I don't know, I put everybody to sleep. I mesmerized them. Someone says, I apologize, I'm driving. If blood thinners are administered after heart surgery, what precaution does a holistic coach have to be aware of? So blood thinners, again, depends on the type of blood thinners. And we use that word blood thinner. They're medications that inhibit platelets, which helps with the early formation of clot or thrombus. Then there are other medications which we call anticoagulants, and they inhibit enzymes that lead to the production of molecules that kind of stabilizes the clot. So some blood thinners, quote unquote, are used for arterial flow clots, i.e. antiplatelet agents, and some are used more for the venous side. They both have some, cross interaction, but that's typically what we use. So it depends on the type of quote unquote blood thinner. It depends on the purpose. Typically someone on a blood thinner, you just want to be aware that if you injure yourself, be able to look out for bleeding, because you may bleeding, swelling in a joint or something like that. Could be worse than if you have a joint injury. But that's kind of the main. Any comments y'all have on blood thinners?
Yeah, I always, they're always cautioned about green foods and things, foods that may have vitamin K in it. And I would just say, if you're working on your diet and you're working on a plant-based diet, ask your doctor to watch closely your levels, your blood thinner levels, to check it so you can see how you can eat a healthy diet, while maintaining a good level. But have your doctor work with you on that, because some patients are just afraid to eat anything green otherwise.
Yeah, no, I think you're right. And I think particularly with warfarin, and my experience with using warfarin is that we just, follow the levels and adjust it accordingly. And most of the time, I don't have to do much adjusting of the warfarin levels. There's so many other things that interact with warfarin, so you got to be aware of those things. So the new anticoagulant agents are not affected. I don't think warfarin is really effective. If we talk about it, I'm not aware of any data showing that people do badly on plant-based diet, but we talk about it so much that it's like, okay, let's do it. So I don't know, but somebody wants to know, is vitamin E a good blood thinner? I've never used vitamin E as a blood thinner. Have either of you used it as a blood thinner? Yeah,
no, I have not, but, and we know that we don't want, many vitamin Ds are synthetic, but no, I haven't seen it used that way. Sometimes with people with no severe cardiac problems, we could, sometimes I've seen capsaicin and, being used for regulating the blood thinness or on the other side, it seems to regulate. But no, I haven't used vitamin E that way.
And what we do know, there's been studies showing that when you go on a plant-based diet, there's a reduction in the viscosity of the blood. It's a reduction of this consumption of animal protein increases the rheology of the thickness of the blood, and consuming a plant-based diet reverses that process. So the blood, that's a literal blood thinning, the reduction in the rheology or thickness of the sluggishness of the blood. So sludging of the blood, itself kind of potentiates plaque formation and the like. And so simply going on a plant-based diet itself helps that process and reverses that. And so that's an important factor. It's really a natural progression. But typically, patients with heart failure, if they have atrial fibrillation, they be on an anticoagulant. And when we are naturally intervening with these patients, if we wean them, we look at their risk for stroke versus the risk for bleeding, and we say, okay, if your AFib burden is severely reduced, your diabetes are reversed, your high blood pressure reversed, and so on, their point score, we call it a CHA2DS2-VASc score, their point score that suggests they're predisposed to stroke. If that goes down, then they're less likely to stroke. And so we may, in some certain cases, wean them off a blood thinner because they've reversed a lot of those risk factors that's associated with stroke. So it all depends, and it's always an individual discussion had with the patient.
Well, Baxter, thank you for sharing those slides. I think it shows how powerful it is for the raw plant-based diet, and how it can transform, very severe cardiovascular issues. And the first patient was at, at the dialysis, end stage, looks like end stage kidney function, and improved quite a bit in addition to the cardiovascular. It's quite powerful, and thank you for sharing that, to know that there's hope in changing our diet and our lifestyle. And hydration, the first patient was, so dehydrated with, medication and diet,
No, and that's exactly right. And I think, I mean, the hydration part, the most important nutrient is water. And we often forget about that. We talk about, where do you get your protein? And what about this vitamin? And we don't get a lot of questions on water. But yeah, he was so, with all the diuretics, he was so severely dehydrated rather. The simple life-saving thing for him is aggressive hydration. Speak podcast. I have high blood pressure. I'd like to know what steps I can take right now to lower it without medications. Anybody want to take that on, or?
Well, I just think it's been said that plant-based diet, that raw plant-based diet is very powerful because you're not getting all those chemicals and preservatives and things like that you're getting in, processed and prepared and cooked food. So that's very powerful. But it should be monitored very closely because we don't know how high your blood pressure is. We don't want you to have a stroke and any complications. So it's not easy to just say, oh, no, you don't need to take anything. We don't know where you are, but definitely you need to monitor, have a blood pressure, monitor, and to monitor and work with your doctor and let them know how it's running. But your diet is the most powerful thing to control blood pressure.
Dr. Montgomery, we have something to add for Brother Speak podcast. Our answer is going to be diet or nutrition. I don't like using the word diet, but nutrition, because that's kind of what we concentrate on. But the reality also is that sometimes we need help understanding what that means. And that's why we do what we do, because, somebody telling you to eat better can mean many different things to many different people. And we all know in our practices, when we talk to our patients, that can mean so many different things. So when we're saying, diet, that is kind of just to get your mind in the mindset, and then you find somebody who can actually help you to understand and teach you what we mean by changing what we put in our body such that it can improve your health. Because you can think that you're doing the right thing for years and not get the improvements that you're seeing, and then you get frustrated and say, forget it. So I'm just saying, just be mindful of that. It's a process. It's a stepwise process. And it does sometimes take people to help us to get the results that we need.
Yep, no, that's exactly right. It is, and high blood pressure can be a complex disorder to manage. But you're right. Starting with a healthy plant-based nutritional regimen is where I start all of my patients, because I see it as a foundation. It's sort of like saying, well, I need a house. I need to build a house. Where do I start? Well, you build the foundation, and so your foundation for treating your health is going to be optimal nutrition. That's going to be removal of the bad and adding of the good, and then you're going to add other things: proper sleep, rest, fresh air, sunshine, exercise. All those things are part of that foundation of your health. And then, there may be nutraceuticals if needed. So maybe L-citrulline would be a nutraceutical that would be beneficial. Magnesium may or may not be a part of that. And so you may add that. And then, pharmaceutical only as the last resort. And so you start with the foundation: optimal nutrition, fresh air, sunshine, exercise, rest, grounding, and stress management, those types of things. Then nutraceuticals as needed, and then pharmaceuticals as the last resort. So that's certainly, I agree with everything stated above. Heart failure, heart murmur, CoQ10, what should be, I use CoQ10 in a lot of patients with heart disease. CoQ10 enhances mitochondrial function. You might argue that a lot of people need it, many more than we do. I use it aggressively in heart failure patients. People who were taking maybe over-the-counter medications, Tylenol or supplements, of other types, processed foods, chemical dyes, antibiotics, they can have an adverse effect on your mitochondria. And so CoQ10 helps enhance mitochondrial function. It's an ubiquinone. So it can be beneficial early on. You may not have to take as much as someone with congestive heart failure. It can be beneficial. A baby aspirin daily, it all depends. In men, if you've had a heart attack, it may be beneficial. I typically use it in my patients who've had a heart attack. Women, it probably benefits in stroke more. But if someone's coming in, they've had previous stroke, previous heart, previous vascular event, I may start them on a baby aspirin until I've got them fully converted onto a natural plant-based diet. and decrease inflammation by other means. You know, aspirin is an antiplatelet agent. It is also anti-inflammatory, and those are probably two mechanisms by which it helps. And so I tend to use that over other agents, but I tend to try to use that only transient until somebody's fully transitioned to a healthy lifestyle. Anybody else? Any other comments on that?
No.
Okay. Let's see. What's the best way to lower blood pressure? I think we covered that. Lifestyle, proper diet, etc. Nutraceuticals needed. Is consuming anyone a good way to thin the blood? It depends. It's probably not the best way if you have atrial fibrillation. You have to use an anticoagulant for that. But again, it can help if you're dealing with coronary disease or vascular disease, and get off blood pressure medications. Dylan Lovelace. You getting off blood pressure medicines is a stepwise process, like Dr. Palmer mentioned. So what exactly does an aspirin do? Does that thin the blood? It thins the blood by decreasing platelets from inhibiting platelets from sticking together, and it decreases inflammation. Those are probably the two most important mechanisms.
Dr. Can I add something in?
Sure.
We were talking off camera about, and a lot of people asking questions about their blood pressure. And so the question that we were talking about with the cholesterol and vascular disease itself, and a lot of people feel like if you're eating cholesterol, that's what makes your cholesterol rise. But you were saying it's not necessarily just that. So can you elaborate on that for the audience so that they can kind of hear what we were discussing?
So the issue of reducing cholesterol, I mean, the statin drugs have anti-inflammatory. You want me to talk in terms of context of the statin drugs itself, or overall aspects of reducing cholesterol?
Cholesterol.
Yeah. So I mean, cholesterol, and I remember that conversation we had. I remember. Okay, this is a weekend off camera. Okay. Yeah. So we look at cholesterol as a process of, well, we're taking in fat or we're eating cholesterol, so the cholesterol goes up. And I think there's some truth to that. If you eat a lot of shrimp and maybe cholesterol-laden foods, the cholesterol will go up. Maybe if you stop eating, it'll come down. However, I don't think it's as simple as that. I think cholesterol in and of itself is a signal of abnormal metabolism. So when I see someone with hyperlipidemia, I think of them in a similar fashion to someone with hyperglycemia. Even though hyperglycemia is diabetes and hyperlipidemia is we kind of put them in two different buckets. I think there's a common denominator aspect of this, and that common denominator is abnormal metabolism. Now, there are probably other aspects of abnormal metabolism, but so let's say you have high cholesterol and you go on a whole food plant-based diet, low fat, so you're not eating any nuts or oils or whatever the case is, and say, I'm not eating cholesterol, why is my cholesterol still high? You still have to look at the foods that you're eating and how you're preparing the foods, that they're preservatives, because foods that are microwaved or chemically preserved, etc., may adversely affect the liver. The liver is where cholesterol metabolism occurs. So abnormal liver metabolism will result in abnormal metabolism. Elevated cholesterol may just be an outward manifestation of that underlying biochemical process. I've had lots of patients who come to me and they're eating a whole food plant-based diet, low fat, and the cholesterol remains high. But then I look at how they're preparing the foods, the processing of chemicals, and I remove that processing element, and then the cholesterol comes down. Inflammation comes down. And so the mechanism of hypercholesterolemia, I think, is more complex than what we know. I think there's an underlying biochemical process that needs to be understood, in addition to the fact that somebody is simply consuming too many fats. Those fats are rancid are probably not just the fact that you're consuming the fats and it's just staying in the blood. Those rancid fats are probably having an adverse effect on the metabolism of the liver in and of itself. And that may be the mechanism by which the cholesterol is high. So that I'm glad you raised that, because we didn't get a direct question to that, but I think this is an important point to raise. High cholesterol in and of itself could be just a simple sign as abnormal biochemical process or abnormal metabolism at the level of the liver or skeletal muscle, etc. And we need to understand that by treating the whole body with natural foods and removing all toxins, preservatives, may help reduce that that cholesterol level. Because I've seen patients with high cholesterol and they're doing all they can, eating a plant-based diet, and I've seen people say, okay, go ahead and take a statin, but that's not the end of the story. And there's more you need to do, and so that's that process.
Yeah, I like to piggyback on that. Yeah, just the emphasis anti-inflammatory. Many times when our blood pressure is up, we have a lot of inflammation causing more plaque and sludge and narrowing of the blood vessels. So we want to emphasize an anti-inflammatory diet, and that's what we get from live food is anti-inflammatory. So the more we eat an anti-inflammatory diet, we not just against meats, but all the starches and the grains that that are prepared and things are done to it. Corn and GMO corn and things like that. Wheat, of course, a lot of people think if they eat whole wheat bread that is good, but that is an inflammatory component. So I just want to emphasize that anti-inflammatory component to get that blood pressure down.
Now that's important. Yeah, the anti-inflammatory and oxidative stress part of it. Dylan Lovelace, I was diagnosed with heart failure. Does that mean for the rest of my life I must eat only plant-based foods? No, just as long as you don't want to have heart failure. What about breads? Yeah, stay away from the whole wheat bread. Ezekiel bread generally is pretty good, but I like to say it depends because we have a lot of patients with heart failure. It depends on how far along you are. And I've developed a lot of respect for heart failure. And so the heart failure patients I tend to be very aggressive with. People with systemic inflammatory conditions I tend to be very aggressive with. And so I would say yes to the plant foods, but not just plant foods. You need to be very aggressive in terms of, how pristine your diet is. And without knowing any details, I can't say more than that. But what I will say hypothetically is when I'm seeing someone with heart failure, I tend to put them on raw fruits and vegetables only. I tend to maybe do smoothie detox feasts. So I aggressively detox these patients. Plus, I'll put them on high-dose liposomal coenzyme Q10, MSM as a baseline, plus or minus. If they have systemic inflammation beyond that, like joint disease and all that, I may add a liposomal curcumin and a liposomal vitamin C. Liposomal vitamin C is usually the third agent I'll add, which helps reduce oxidative stress and to some extent inflammation. So the anti-inflammatory process is important, as Dr. Atkins pointed out. And so you have to be pretty aggressive. So yes to the plant-based diet. I would say no to the breads because there are too many breads that are bad for you. The Ezekiel bread is a maybe over time, but that's there. And of course, our one group, we're going over a little bit, a lot of great questions. How much water should we consume daily for proper hydration? You should consume enough. I mean, I'm not being flippant by that, but anybody else want to take that on?
I just say rule of thumb, half your weight in ounces, but a 90-pound person would be a different amount than a 200-pound person. So that's a rule of thumb, but also how much exercise, how much you're sweating, being exposed to warm weather, etc. We need extra, but at least, a good baseline is half our weight in ounces. I say water, non-caffeinated herbal teas, but of course, as you say, Baxter, plant-based foods and vegetables and fruits have high water content. So we do get more from them.
I was going to have something to add. So I don't like counting water bottles and doing it like that. So I don't do that. So I just try to do it based off of how I'm feeling. If I'm exercising, obviously I'm going to drink more. If I'm not, then it may be a little bit less, but eating definitely in the summertime, a lot of water-filled fruit. So watermelon, cantaloupe are my best friends in the summer months. So I try to do it that way because just drinking plain water is a little bit boring.
Yeah, I agree. The plant-derived waters are good. And one barometer you can use, because it's hard to know, as Dr. Atkins alluded to, this amount for this weight, but then what if you're exercising? What if you're this? If your urine is clear as water, that's a simple little test to say that, okay, I'm hydrated. So the body's putting out a lot of clear water. If it's yellow, dark yellow, then chances are it's holding on to water. There's a lot of, concentration, so you need to drink more. So you can use that as a simple barometer. Hydrate yourself, whether it's with, clean alkaline water or ideally eating your water with a watermelon or whatever. If your urine is completely clear like water, that's a good sign that you're pretty well hydrated. You're just putting out extra water. And so, barring somebody with kidney disease or low sodium, that would be what I'd recommend to be the case.
And another quick thing, sometimes another way you can tell if your body's properly hydrated is your skin and how dry your skin is. Sometimes, and I'm thinking about the kids, I'm thinking about children, pediatrics. A lot of times kids are, they have very dry skin, eczema, rashes. And I feel like a lot of it's just from dehydration because they're not getting in enough fluids to kind of keep those cells turning over and functioning they should be.
Yep. No, I think you're right. I think it's with kids, it's certainly important from that standpoint. Does sugar increase blood pressure? There's some adverse biochemical effects of processed sugar that indirectly and in some cases directly can be associated with high blood pressure. We use these sugars only as a transition. I recommend that you consume, if you're getting sugars, it should be in the form of whole foods, dates or the like. We do have recipes that have agave in them, but most recipes we recommend are without any processed sugar whatsoever. And my thinking on the sugar has evolved over time, and we should be a little bit less aggressive in recommending the removal of sugars. We are more aggressive now because we find many of our patients, they kind of stay there with all of these processed sugars. And you want to get to where you're eating whole foods without added sugars like agave or honey. You may want to eat a date from time to time, but eating foods that don't have even a lot of these fruits and high glycemic index foods is good for you. And so there's certain ways of doing that, and we work with our patients to help them do that. And you can have foods that are very tasty. So the sugars don't have to be there. You're going to get sugars from, really spinach and things have carbohydrates. So you're going to get sugars from foods in a natural way. Healthy fruits, low glycemic index, give you the carbohydrates that you need. So you don't really have to do them in a processed format. I was going to add to that. Y'all are amazing. Okay, wait, thank you very much. Are y'all still enjoying juice feasting? I'm still on the juice feast. The other groups broke away.
You know what, Dr. Montgomery, I am still too. I didn't eat anything today. So today was supposed to be my break day, but I was so busy with doing things. It's easier to just grab the juices and keep moving. So
you might be stuck for 60 days. There's a rule.
It's not going to be 60, but
that's good. So the two of us still going, and the other group. So that's good. But anyway, no microwave. How about Instant Pot or air fryer? I say no to microwave, definitely. Air fryer, I say no to. Instant Pot, I think is okay. Anybody, y'all have an opinion on this? Celeste and Pam?
Yeah.
Okay.
I like air popper. I like air popper for I guess if you want to do organic non-GMO popcorn, but I know microwave. I think microwave destroys the nutrition of the foods. So you're not getting any you're not getting the good nutrition from your foods if you're microwaving it. So perhaps generally heating it, but people that eat raw may get a dehydrator and which gently warms things, but under a certain, you usually want to stay under 115 degrees. So, but no, absolutely no to microwaving for me.
So the air fryer, can you pop popcorn in the air fryer? I've never used an air fryer before.
I've never used the air fryer. I was talking about air popper. Yeah. So yeah. I'm not familiar. Maybe somebody else is familiar with the air fryer.
The chat room, they can throw that. Okay, so deep anti-inflammatory, yes. Good conversation. Thank you very much. Let's see. Is stevia good or bad? I had a stevia plant. I think if you're getting from the stevia leaf, it's good. There's some stevias that have preservatives in it, so you have to be careful where you get your stevia from. It's been my experience. I was in your office back in 2019. I still follow you. Looking forward to the meal plan I signed up for. Is this still available, or do we have to find foods ourselves? No, the meal plan is available. Not only is the meal plan, if we have the legacy meal plans, and we actually have a grocery plan, which is a spectrum of prepared foods to groceries. And so we'll work with you not only on an initial detox, but we will prep the food and then show you how to prep it yourself and help you create grocery plans to stick to a nutritional regimen. So if you have an upcoming appointment with us and so on, we look forward to seeing you to work with us on the meal plan. So we do work with people directly with their food and with meal plans and grocery plans now. And that's the wave of the future, because we have to look at how we procure our food and what we get. So anyway, well, this has been a very little bit long show. Oops, I'm sorry. Let's see. Please give me a link to that. Then Lovelace, do you have an office number? Let me just give you the office number. I'm just going to put that in the chat room. And also, that's just to call us. And also, if you have trouble getting in, sometimes our answering service doesn't get the message to us. Just call after hours, and they'll get me directly, and I'll put you in touch with getting an appointment. But anyway, so as I said, heart failure is a very complex issue, but in some ways it's complex, in other ways it's not, because the fundamentals are the fundamentals. So whether you're treating diabetes or high blood pressure or heart failure, you want to start with a fundamental process of improving your overall biochemistry and what have you. And so I want to thank my colleagues for a healthy discussion. I'm going to see you guys backstage as I close out. Again, I hope you got information from this, that found the information here valuable. If you did, I'd like for you to hit that thumbs up. Also, if you haven't subscribed, please subscribe. This is beneficial to us to help promote our channel and help us get the message out. Again, heart failure is very complex, and pass this information on to someone, a loved one, a friend, or someone you may know who's suffering from heart failure. I think they can get some good information from here. And by all means, I think there's always hope. And so, oftentimes, my colleagues will say, hey, there's no hope and you got heart failure, you're going to die. We've seen patients with severe heart failure, and if you do the right thing aggressively enough, you can turn it around. So if I don't deliver any other message to you or anyone else who's looking at this, is that there is hope. So reach out to us if you have any questions. We're here to help, and we're here for you. And again, pass this video on to anyone who could benefit from it. So until next time, keep it fresh, natural, and live. And thanks for supporting the show tonight.